Hello, everyone, and welcome to another episode of Let's Talk Hereditary. Dr. Church, thank you for being with us today. I have to comment on the Pooh Bear tie. It's one of my favorites, so thanks for wearing it. All right, today we're going to talk a little bit about polyps and other polyposis syndromes. So what are the different types of polyps that we see when we're doing colonoscopy on patients?
Well, there are lots of different types. We broadly define them into neoplastic and non-neoplastic. That is, those that show abnormal growth and those that show uncontrolled growth. Uncontrolled are the ones that are going to turn into cancer. So those are the adenomas and serrated polyps. Those are the two main ones. Then there's the other sorts of polyps, the hamartomas, which are a benign proliferation of tissue that's normally found at the site. And then there are other ones like lymphoid polyps, inflammatory polyps. Sometimes the tissue looks like a polyp because it's a bump, but there's nothing wrong with it, so normal polyps. Those are the main ones.
Okay, so when we think of those polyps, and we talked about neoplastic polyps, when we think of all the polyposis syndromes, how do you classify them in your mind? Like when you think of all polyposis syndromes, how do you think about them?
Well, I divide them up histologically, so that syndromes of an adenomatous polyposis, so these are adenomas. This is the first step on the way to cancer. These are the high-risk cancer syndromes. Then there's the serrated polyps, which are also neoplasms, and they are precancerous. Whether it's inherited or not is a different matter, and hopefully we'll talk about that in a different topic. But then there are the benign ones that theoretically shouldn't turn to cancer at all, and these include the Hamartomatous syndromes. And really that's the only other group of hereditary polyposes.
So we talked about Hamartomatous polyps. Are those polyps cancerous at all? Like, does the polyp itself turn into cancer or no?
It can, and there is a high risk of colorectal cancer associated with these syndromes, but it's very rare. Usually the cancer arises in an adenoma that just shows up in a field of Hamartomatous polyps.
Okay, so how many syndromes do we know of Hamartomatous polyposis are there?
Well, there's at least 3, and I say that because there are 2 definitive syndromes, Peutz-Jeghers polyposis, juvenile polyposis, and then 3 other syndromes have been grouped into the P10 hamartoma tumor syndromes because they all share at the same genetic origin, a P10 mutation.
So let's talk about each of those briefly, but let's talk initially about juvenile polyposis. First of all, what does the word juvenile mean?
Well, it originally came into being because these were polyps found in children, and they still are. Sporadic or single juvenile polyps can often be found in children. They can cause bleeding. They sometimes auto-amputate, like just drop off. So we still find them, but that was what led to their name.
But that doesn't mean they're only found in children. We can see them in adults, right?
Well, as you can see, single juvenile polyps in adults, but juvenile polyposis also has a version that happens in infancy and childhood, quite a severe version, but it's more commonly seen in adults.
Okay. And what is the risk of cancer in this population or in the patients with this syndrome?
Well, like any degree of polyposis, it depends on how many polyps are in the colon at one time. So you can have a patient with a handful of polyps, they're at relatively low risk, but we don't rely on that. And then you can have patients where the colon is pretty much carpeted with polyps, and they have to be at high risk, and then we would probably take that colon out. So there's a range of risk. I can't give you an actual number because it depends.
So it depends on the screening that we're doing for those patients. Is there a rigid colonoscopy screening for patients with juvenile polyposis, or that's flexible based on how their colon looks like?
There's a baseline, probably every 3 years. You wouldn't want to wait any longer than that. A lot of it is not just screening because these polyps can be symptomatic. So in order to control the symptoms, we want to go in more commonly and take out polyps. Then if we find we just can't keep up, so some of these patients have a very aggressive polyp-forming phenotype, then they need surgery.
Okay, the second syndrome was Peutz-Jeghers syndrome. Can you tell us a little bit about that? And there's usually a couple of like presenting symptoms that the patients present with if they don't have a genetic label initially on them.
But let me just back away a little bit and remind ourselves that these are hamartomas, so they're an overgrowth of tissue that is normally in that organ. So for Peutz-Jeghers, it seems to be an overgrowth of the muscularis mucosae. So the thing that's growing fast is this thin muscular layer at the bottom of the mucosa. And as that grows, it sprouts up into a polyp. And then the epithelium that we would normally see as in an adenoma gets taken along with it. So if you biopsy a Peutz-Jeghers polyp, you see this muscle going up through all the branches of the polyp with normal, slightly inflamed mucosa on top of it. For juvenile polyposis, what's overgrowing is the lamina propria, which is the supportive layer of the epithelium. So the crypts are surrounded by lamina propria. And what you see in those polyps are big mucus spaces and a lot of inflammatory cells. So sometimes they're called inflammatory polyps. But again, the mucosa is normal. So the mucosa is not going to produce a cancer. You're not going to get an adenoma or a cancer as the main cause of cancer. You can sometimes get an adenomatous change in the middle of a hamartomatous polyp or a separate adenoma, and that's where the cancer comes from. So back to Peutz-Jeghers. Peutz-Jeghers is a condition where lots of these hamartomatous polyps occur mainly, say 75%, in the small intestine. This makes it unique in terms of the hereditary polyposes. And when you get big polyps in the small intestine thinks it's a piece of food and tries to move it down, and that generates a stalk of the polyp, and if it keeps happening, it makes the small bowel turn inside out. And we call that an intussusception, and it presents as a bowel obstruction with crampy pain as it's happening. So that's quite common in teenagers or even sub-teens with juvenile polyposis. But the easier way of recognizing those patients is with freckles on the lips, pigmented spots on the lips, the buccal mucosa that are most intense in the first decade of life and then tend to fade after that.
When those patients present with an obstruction due to intussusception from those polyps, how do you manage those patients in the OR? Do you just resect that piece of bowel, or do you take the polyp out, and what do you do with the rest of the bowel?
Well, the main therapy these days is endoscopic with double balloon endoscopy and polypectomy to try and avoid surgery completely. Sometimes you can't, and if an intussusception has happened, then I don't think endoscopic way is possible. So then we have to do surgery, and there are two ways of approaching the situation. One is to just go and take out the obstructing lesion, and then you're done and you close up. What you're doing then is leaving other polyps that might be present in the small intestine. And you would probably know that they were there because these days all these patients get magnetic resonance enterography or CT enterography or a capsule endoscopy. These are ways of looking at the entire small bowel without putting a scope down it. So it gives you an idea of the polyp number and size in the small bowel. But so when you operate on someone with an obstructing intussusception, you can either deal with the obstruction and that's it, or you could clear out all the polyps in the small bowel with a combination of endoscopy from above and below and judicious surgery. And those patients, that we like to call this the clean sweep operation, do much better. They have much less episodes of obstruction over the subsequent years of their life and need much fewer surgery.
You talked initially about a difference in how the juvenile polyps are different than the Peutz-Jeghers polyps. So a pathologist can tell the difference between the two hamartomatous polyps, right?
Absolutely.
And are both syndromes have the same gene mutation, or are there different genes for both of them?
There are different genes. The Peutz-Jeghers syndrome comes from a germline mutation of the STK11 gene, which is stands for serine threonine kinase, which is an important tumor suppressor gene. And the juvenile polyposis, we know of two genes that are implicated in that. One is SMAD4, which is an interesting gene because it's part of the regular colorectal cancer pathway genes. And the other is BMP1A, which stands for Bone Morphogenic Protein Receptor 1A.
I didn't understand the English, but what is the difference between those two genes?
Well, they both cause juvenile polyposis, so that's a similarity. And they both do it because they're normally tumor suppressors, but how they impact the pathways of cell growth is slightly different. The SMAD4 mutation is more severe. It's associated with worse gastric polyps, which is a feature of patients carrying that SMAD4 mutation, and a higher risk of colon cancer and more colon polyps. And in addition, they developed this, you would think it was an unrelated syndrome of hereditary hemorrhagic telangiectasia, which is abnormal blood vessels in a variety of organs that can cause serious symptoms and serious side effects if you're operating for other conditions. So we always screen patients with a SMAD4 mutation for HHT.
So those are two syndromes of hamartomatous polyps. There was a third syndrome or a group of syndromes you were talking about. So what is that? Can you might tell us a little bit about it?
This is the P10 hematoma tumor syndromes, which includes something that you might be aware of as Cowden syndrome, and Benayan-Ruvalcaba-Riley syndrome, and Proteus syndrome. So these are generalized syndromes of generalized growth abnormalities. Their involvement of their colon and rectum is kind of peripheral. There isn't a specific polyp associated with these syndromes. What they get are a variety of mesenchymal polyps, such as fibromas, lipomas, ganglioneuromas. Sometimes they get adenomas. And there is a moderately high risk of colorectal cancer, about 9% in these syndromes. Because they're all of the same gene, it makes you think, well, should we call them different syndromes when it's coming from the same gene? Because there is a lot of overlap between the phenotypes of each of these genetic conditions. So that's why the move has been to call them all P10 hematoma tumor syndromes rather than by their other names.
Okay. Well, Dr. Church, thank you for being with us today. Thank you, everyone. And if you have any questions or concerns, feel free to reach out to one of us. Although Dr. Church used a lot of hard words to me today, but that's the main purpose of those interviews, is to learn and know more about those syndromes and talk to people who actually understand them. Thank you.